Tonight we're going to start off talking about hematologic disorders. This is left over from last week. I'm going to try to fix my technology here. There's too many things to keep track of. Well, it looks like my clicker is not going to work, so I'm stuck up here with slides. Well, I may be stuck altogether. There we go. Okay, so we have objectives for tonight to look at some normal clotting mechanisms, look at some particular diseases, hemophilia A and DIC, and then some hematologic cancers. And then we're going to look at complete blood count results and figure out what those RBC indices mean if you've never looked at those before. So starting with hemostasis, initially the first reaction when we have an injury that interrupts blood vessels is vasoconstriction. And that's a really quick response, and the purpose of that, of course, is to interfere with bleeding, to stop bleeding as much as possible. And then within just a few minutes, platelets come to the site and add a clot to the area to prevent blood from leaking out. That continues on for several minutes. And then we also have our clotting factors come and add to the clot that's being formed. But it takes up to an hour to get a good clot to form. That's why you know you can remove a new clot really easily if you're talking about external. So if you draw blood from somebody, even if you do a chem strip, you know, if you come back not too long later and push again, you might get some blood out of there. So it takes a while for that to firm up. This is a picture of a platelet and then an activated platelet. So this one is the activated platelet. And this is from a website, Dennis Kunkel, who does microscopy. He's got tons of microscopic pictures of various things. You have to get permission to use them, and I have his permission to use them, but if you go to his website, you can look at all these pictures. They're just incredible. I've got some more in some of our PowerPoints as we go along. So platelets, another name for them is thrombocytes, about 150 to 350 or 400,000 per cubic millimeter. Their lifespan is only about 10 days, so we're turning over platelets very rapidly. About 70% of them are circulating in our bloodstream, and the rest of them are stored in the spleen, just waiting there, sitting there, so that if we need them, they can be pushed out into the circulation and go to an area of injury so they can participate in clot forming. Stress, epinephrine, exercise all increase platelet production, so it's not unusual to see, especially a hospitalized patient, with a slightly elevated platelet count just because of the stress response that they're experiencing. Platelets go to the area where the injury is. They do more than just physically form a clot. They release chemical mediators that participate in the clot formation. They contribute to vasoconstriction and also they release mediators that encourage other platelets to come and stick to them. And they're also important in healing. So we talked about that a little bit with inflammation, that the inflammatory process sets the stage for healing of an area, and platelets participate in that healing process. Besides platelets, we also have a variety of clotting factors. They're all made in the liver except clotting factor number 8. They're all named with Roman numerals. They circulate in their inactive phase, and then when we need them, again, they're triggered to morph into an active substance. And I have a picture of this, the intrinsic and extrinsic pathway. It's just different ways that the clotting mechanism gets started, and they come together and join in the middle, and then the end of the pathway is the same for both. And what the clotting factors do is they contribute to the formation of the fibrin there. So here's the cascade, and you can see the intrinsic pathway and the extrinsic pathway, and then they come together and have a common pathway at the end. Now, one thing to note about this is the first one that's activated is not number 1. They're named in the order that they were discovered, not in the order that they activate, which is really annoying because it would make sense if they were numbered 1 through whatever, but they're not. I wouldn't expect you to memorize this. I would like you to understand that there's 2 different ways to trigger the clotting mechanisms, the intrinsic and extrinsic pathway, and that they do come together at the end. Now, we talk about clotting all the time, especially as nurses. We talk about giving patients anticoagulation to prevent clotting. We talk about clotting factors and platelets and all of that. But we also have in our body things that are trying to break down clots. So we're just an ongoing continuum of forming clots and breaking down clots and forming clots and breaking down clots, and that's happening simultaneously. So as soon as a clot is formed, we start the release of factors that are going to break down that clot. Now, plasminogen activators cleave or cut plasminogen into plasmin, and plasmin is a substance that digests clots. So when that happens, then we get fibrin split products or fibrin degradation products. So these are things that we can actually measure in the bloodstream, and it tells us that clotting has been happening. We also have natural anticoagulants in us. So we can give people Coumadin or heparin, but people have anticoagulants in them all the time as well. Macrophages help break down clots, and they clear up debris at the area and move it out of the way. And then this bullet, I always have to stop and think about this. So there's too many, it's like quadruple negatives in there. So we don't want, well, first of all, what's fibrinolysis? Clot breakdown, okay? So we don't want inappropriate fibrinolysis, right? So we have antiplasmins that inhibit inappropriate fibrinolysis, okay? So plasmins, we saw on the last slide, let's go back and look at that. Plasmins digest the clot, and then there are antiplasmins to prevent digestion of clot when it shouldn't happen. Okay. Here's another picture from Dennis Kunkel. It's a red blood cell inside a capillary, and you can see, we talked a little bit about this, I think, I can't remember if it was the first night when we talked about sickle cell anemia and how the red blood cells go one by one through the capillaries. That's all there's room for, and you can see that that red blood cell is just squeezing through there. So when you have sickle cell anemia and the red blood cell changes shape, it can't get through that narrow passageway because it's so distorted in its shape. Here's red blood cells trapped in a fibrin clot. So this is inside the cell where we can see the clot formation process happening, the fibrin coming there, and then creating this clot, and then the red blood cells are getting trapped in it. So just some terminology for you to be familiar with. Petechiae are the little pinpoint red flat areas. We often talk about petechiae on the chest, but they can happen anywhere. Various diseases cause them different places. And that's just hemorrhage of little capillaries in the skin. Purpura are when patches of petechiae come together and form a continuous area, and we've got some pictures of these. Purpura is often itchy. Ecchymosis is just a fancy name for a bruise. Hematoma is accumulation of blood under the tissue. And when you're caring for patients who might have a hematoma, it's important to remember that they may or may not have ecchymosis. So you could have blood accumulation under the tissue and not see anything on the surface. So how do you tell if somebody has a hematoma? Palpate. Palpation is the way to tell, and it'll feel firm. And then hemarthrosis is bleeding into a joint. So here's petechiae, little pinpoint red areas. There's purpura, where we see patches of them together. That's another picture of purpura. Somebody's back. There's ecchymosis. I'm guessing that's an IV site or a lab draw. So when we're evaluating people with hematologic disorders, there's a number of tests that can be done. Certainly a complete blood count, primarily because it gives us a platelet count. That's going to tell us about that clotting factor. The PT-INR and the PTT. So the PTT is the partial thromboplastin time, PTT, and that tells us about one particular component of the clotting pathway. We monitor that when we're caring for patients who are on heparin, because heparin elevates the PTT. It makes it the number higher, prolongs that clotting mechanism, so it takes longer, so it takes more seconds, which is how it's measured. And then some places are starting to use, instead of the PTT, they're using the anti-10A. And that's just, it's like doing the PTT, it's just looking at a different level in the clotting cascade. that's closer to where the anticoagulation needs to happen. So it gives us a more accurate reflection of the heparin dose that the patient's on, anti-10A. Are you seeing that used in your clinical practice? Some of you are, then some of you aren't. And then PT is the prothrombin time, and that's the basic test that's done, but then it's standardized into an INR. And the INR is the International Normalized Ratio, and that allows us to compare PT values across labs and across cities and countries where you can't do that with a PT. So it's just a standardized version of the PT. It doesn't have any units associated with it because it's a calculated number. But that's usually what we're tracking when we have people on anticoagulation, and the INR is to monitor the effectiveness of Coumadin. Then fibrin split products or fibrin degradation products, FDPs, measured using a D-dimer test. You see that ordered in some cases, and that just lets us know that the patient's having some clotting issue. We check that for patients with pulmonary emboli, any kind of clotting problem, and also with DIC, and we're going to talk about that a little bit. And then the coagulation factor assays, we can actually just measure the level of those various coagulation factors. So if we're concerned about a patient with hemophilia and we're concerned about clotting factor 8, we can measure clotting factor 8. We can just measure how much is there in the bloodstream. Ooh, that's bats in Olympia, Washington. They gather somewhere down there in Olympia, and then they take off in the middle of the night, and somebody got a picture of one. Okay, so hemophilia A. Now, there are a variety of types of hemophilia, A, B, C, and we're just going to talk about hemophilia A, which is what 85% of hemophiliacs have. For 80% of patients, it's an X-linked recessive disorder, so we could draw our Punnett square and see what the risk for offspring of people who are carriers or are not carriers and so on have the disorder. But for 20% of patients, it's just a spontaneous mutation. So they look back at the genetic tree of the family, and there's no evidence of hemophilia in the past. It's just a new spontaneous mutation that's occurred. It's a deficiency or a malfunction of factor VIII, so they either don't have enough or what they do have isn't working well. And because of that, it interferes particularly with the intrinsic pathway. That's where factor VIII comes in, and the end result is bleeding. Now, there are different levels of hemophilia: mild, moderate, and severe, depending on the amount of clotting function that the person has. So with severe hemophilia, they have less than 1% of their clotting function available to them. In assessing patients, we're looking for evidence of bleeding, and with mild hemophilia, patients may be completely asymptomatic. We may not see signs and symptoms at all. With moderate, they will begin to see bleeding just with minor injuries. It doesn't take much to get them started, and they start bleeding and have those bleeding episodes, or they might have spontaneous bleeding with no known cause, no injury, nothing that we can see triggered this. But people with severe hemophilia have spontaneous bleeding all the time. And so there's no trauma that happens, they just start bleeding. And usually we're talking about internal bleeding rather than external bleeding. Now, if they get cut, they're going to have problems with that as well. But that's initially, as we just saw, a platelet issue, not a clotting factor issue. But what they do have is internal bleeding. So we're looking at joints and looking for joint deformity as blood accumulates there. We just said that was hemarthrosis, so we can see that accumulating in the joint. Bleeding from the mucous membranes, GI bleeds, blood in the stool, blood in the urine, looking for all of those. And then when we see kids that have strokes, often we need to look at hemophilia as a potential cause with intracranial bleeding. So with mild hemophilia, they're often not diagnosed until they're an adult. They have rare episodes of bleeding. Usually it requires some event to trigger it. And so they may get through childhood just fine, and it's not until they're in adulthood that we find out that they have hemophilia. With moderate hemophilia, as soon as the kid starts moving around and bumping into things and falling over and those kinds of things, they'll start to have bleeding episodes, and so we can see that in childhood. With severe hemophilia, we see it shortly after birth, often when we give the vitamin K injection. They bleed from that site, and we're able to see that they get tested then for hemophilia. So for diagnosis, the best thing is to measure that level of factor VIII and see what that level is. And obviously we'll see that it's decreased. Now, because of where the clotting cascade is affected, the prothrombin time in these patients is normal. But the PTT, the partial thromboplastin time, is increased. And then the bleeding time, which is another test that's done, is prolonged. And I don't know if that was on that list before, but I must have skipped over it. So the bleeding time, y'all know what that is? It's where they actually make a little scalpel incision in your forearm, and then the lab tech sits there and waits to see how long it takes to clot. So it's kind of a crude test. It looks kind of barbaric, you know, to go make a slash in somebody, and then you sit there and wait and see how long it takes to clot. So it would be prolonged in people with hemophilia.
Do you know why they would choose to do a bleeding time versus checking the other labs?
You know, I don't. That's a good question. How do we choose which diagnostic test? Clearly, the coagulation assay is going to tell you exactly how much factor VIII they have. It may be a matter of narrowing down what the possibilities are to get more specific. Or it may be that they're doing a bleeding test before they figure out that it really is a hemophilia, and then they go measure the coagulation factor assay.
Well, I know that bleeding times used to be used for surgery a lot
Uh-huh.
than they do now.
Mm-hmm.
But just to see what reactions to pay.
Yeah, my guess is that if there's a decrease in the use of bleeding time, it's just because we have other better diagnostic tests to use. Yeah. Has anybody seen a bleeding time used lately?
My first physiology class, we had to do it on each other. So
Oh, fun. So have you seen it used?
The last time.
Yeah, so you haven't seen it used clinically. Yeah, it's been a while since I've seen one, but
I haven't seen it used since the 80s.
yeah. Okay. In the cath lab? Okay. All right, so treatment for people with hemophilia. Well, clearly preventing injury is going to be important. Now, we have to balance that, especially when we're talking about kids, in terms of restricting them too much from activities and preventing them from playing with their friends, but still protecting them from injury. So that's a difficult balance, you can imagine, for patients. Immobilization of hemarthritic joints. As long as it appears that there's bleeding in the joint, and so as long as there's swelling there, we need to immobilize the joint and not be moving it around so that it can stabilize and not continue to bleed. Clearly, they have to avoid aspirin, and you know aspirin's in everything, all kinds of medications, cold medications, sleep medications, all kinds of things. So patients have to be careful about reading labels so they're not getting aspirin in. Patient and family education, and then potentially genetic counseling, because it is a genetic disease, to see risk for future siblings or for the kids of the patient that has the hemophilia. Now, we can give factor VIII replacement, and that's administered intravenously. We can get it by giving blood products, but rather than that, these days what we give is recombinant therapy in the form of Refacto. Now, some people might get regular replacement of that, particularly people with severe hemophilia. Now, if you have mild hemophilia, you're not going to take that on a regular basis. You're going to take it when you need it if you have a bleeding episode. Then another treatment that's used is desmopressin. That's another name, that's a form that we give people of vasopressin, or ADH, antidiuretic hormone. That's what that is. So what it does is it promotes the release of factor VIII that you might have stored in your body. Now, it does lose its effectiveness over time, but it's helpful to give under certain circumstances when we want to make sure that people are boosted up in their coagulation if they're going to undergo some kind of procedure that could increase the risk of bleeding. If they do have bleeding episodes, we can replace blood products as needed, giving packed cells. If they have moderate to mild bleeding episodes, we can give fresh frozen plasma because that contains the clotting factors that we want to replace. And if they have severe episodes, we can give cryoprecipitate, which is a lot of factor VIII concentrated in that blood product. Then 20% of people develop an antibody to factor VIII that we administer. So they need factor VIII, we give it to them, and they develop an antibody to it. So we can do plasmapheresis, which removes plasmapheresis does a variety of things. In this case, we're talking about removing antibodies from the patient. So plasmapheresis can be used for a variety of autoimmune diseases to remove antibodies. It's also used in people that have very high cholesterol levels to remove their cholesterol. And it's also the same process that's used when you do a platelet donation. You donate your blood when you're donating platelets. They take your blood, filter out everything but the platelets, give everything else back to you, and keep the platelets out. So that's a form of pheresis as well. Okay. Anybody cared for, let me go back here for a minute. We'll stop on this one. Anybody cared for somebody with hemophilia? Give us,
Just a long, long time ago, probably 8 years ago.
okay.
And he just came in, like, I don't remember how often he came after it.
So a patient who came in with bleeding episodes, or was this in an acute care setting?
No, actually.
Outpatient setting? Oh,
I mean, he wasn't, like, severely bleeding.
so but he came to the hospital.
Absolutely.
So on the med-surg unit in the hospital with bleeding episodes, and you administered factor VIII and then sent him home. Good. Anybody else? Oh, Kara?
Yeah, a common frequent flyer.
Uh-huh. And how old is he? Okay, so a young man with hemophilia who comes in with injuries, joint injuries or whatever, like sports injuries, those kinds of things, comes in and is there though for 7 to 10 days getting clotting factor VIII. And what else did you say? And pain medications. Yeah.
His brother actually has it as well, but he just has a more mild form.
Okay, so his brother has it also, but a more mild form. Yeah, good. Okay. So we'll move on and talk a little bit about DIC, disseminated intravascular coagulation. This is a bleeding syndrome that's acquired. It's not a congenital one. It's something that happens to you. And it's due to some kind of traumatic injury, event, illness, like sepsis or motor vehicle accident. It happens in OB cases, abrupto placenta and other cases. And we're going to hear a case report about this tonight in just a little bit. 1 in 1,000 or 2,500 adult admissions, and the mortality rate is very high. So this is a scary thing when you hear this diagnosis of DIC. People don't do well with this. What we see is widespread activation of the clotting cascade. So the clotting cascade gets activated and is triggered throughout the body. We get blood clots forming inside the blood vessels. So we have thrombosis, which leads to occlusion of the blood vessels and ischemia of the tissue that those blood vessels are supplying. So if we're talking about heart, we're having heart attacks. If we're talking about brain, we're having strokes. Wherever this is happening, we can see ischemia. The formation of the clot also triggers anti-clotting mechanisms. So we have plasmin activated to break down clots. The clotting factors and the platelets gets used up, and we end up with bleeding. So we have clotting in parts of the body and bleeding in other parts of the body simultaneously. They're both happening at once. And then here's a little more detailed picture. And I just want to point out a couple of things on here. Again, I wouldn't expect you to memorize this or anything, but you can see over in the top left all of those immune mediators that we talked about a couple of weeks ago: kallikrein, bradykinin, and then plasminogen, plasmin. The complement system is activated. Platelets are involved and aggregate. And all of this leads to fibrin clots. Thrombin is activated. And then on this side of the equation, we end up with hemorrhage. Here we get microthrombi with those fibrin clots, vascular occlusion, ischemia, and the development of multi-organ dysfunction syndrome. We're going to talk about that a little bit as well. So the development of DIC can lead to multi-system dysfunction, multiple organ dysfunction, but sepsis can also trigger DIC, and sepsis is associated with multiple organ dysfunction. So they're all linked together. So clotting is happening in the microvasculature and hemorrhage everywhere else. And so often what we see is bleeding out of IV sites, from lab sticks, in the gums, in the urine. We just see bleeding start. And that's often the first sign before we see clotting, although the clotting is the initiator of it. But we don't necessarily see that to begin with. So bleeding happens. We see bruising and petechiae, and then clotting, often mottling of the extremities, the fingers and the toes, as clots occlude those blood vessels supplying that tissue. And then clots anywhere in the body: acute renal failure, pulmonary thrombosis, stroke, as I mentioned, heart attack, other kinds of ischemia as well. There's a little baby with DIC with gangrene of the toes. So the diagnosis is made when we see someone bleeding and can't explain what that is. And then we look back at their history and say, well, they came in with a motor vehicle accident, or they had multiple blood transfusions, or they're an OB patient and something happened. Whatever it is, we can look back at that history and figure that out. And then we can see again some of the coagulation indicators are increased, some are decreased. It just depends on where in the clotting setting they are and what's being affected. And then that D-dimer test is what confirms for us the presence of those FDPs. So the treatment is to treat the underlying cause, to try to get that managed as best as possible. And then whatever kind of organ support the patient needs, usually a ventilator, maybe a cardiac balloon pump, aortic balloon pump, whatever it is, dialysis, whatever they need to support their organs. We can give packed red blood cells to treat anemia because they're bleeding, and then fresh frozen plasma, platelets, cryoprecipitate to replace those clotting factors. And then for the clotting that's happening, we're also giving heparin at the same time. So it's kind of weird because we have these patients that are bleeding and we're giving them heparin, but their clotting factors are used up, so we need to give them something that prevents them from clotting more. That wasn't a sentence that went together very well. They're clotting in various places, so we need to give them anticoagulants to prevent further clotting from happening. So I'll tell you my big DIC case, and then we've got a classmate who said that she would share her story as well. So I was working in the intensive care unit, and I can't remember if I said this at the beginning of the class, but I don't treat anybody under 18 and anybody that's pregnant. So when the OB unit called me and said they were sending me a patient, I was like, you're not going to do that. I don't do OB. But I got overruled, and the patient came to the intensive care unit. She'd had a ruptural placenta, and besides that, she had multiple blood transfusions while she was in the delivery process. And as a result of that combination, ended up with DIC. And I don't remember all the details about the case, but she was a classic picture. We were giving her heparin and administering clotting factors and so on. She was on a ventilator. She was there for a number of days. She did recover. She came off the ventilator and was able to be discharged and be fine. It was interesting. This was back in, I don't know, the late 80s or early 90s or something. And I did catch her one day in the bathroom smoking after she came off the ventilator, which upset me a little bit, but that doesn't happen too often anymore in hospitals, but back then it did. So I'm going to mute my microphone for a little bit. I'm not sure if the recording will go on or what will happen. It may be, you may just hear a blank period of time here, but I'm just going to turn it off for a minute. Okay, so after several minutes off here, we're back now and heard our classmate's story about her experience with DIC, so thank you for sharing that. All right. A hummingbird. Okay, we just want to talk for a few minutes about some of the common hematologic malignancies, leukemias, lymphomas, and then a little bit about multiple myeloma. We're going to go through this pretty quickly, but just to give you a big overview of some of these things. So leukemia is where there's a malignant stem cell that produces neoplastic cells, proliferates and creates these malignancies. We often see a lot of immature cells, the blast cells. And when we have something that's interfering with the bone marrow function, we also have problems with the other blood products coming out of the bone marrow as well. So it's not just white blood cells, it's red blood cells and platelets. And then we often think of leukemia as circulating just in the bloodstream, but it can infiltrate tissue as well. So we can get solid tumors with leukemias. Now, the major types that we're going to look at lymphocytic leukemia, which can be T cells or B cells, and myelocytic can be granulocytes, monocytes, erythrocytes, or megakaryocytes, which are the precursors for platelets. So although it's leukemia, which is white blood cell, you can have red blood cell leukemias and platelet leukemias as well. They're much more rare than white blood cell leukemias. And then we're going to compare acute and chronic. So acute is a sudden onset of symptoms where we have a large number of blasts in the bone marrow and failure of the bone marrow to do all of its other functions. And then chronic, where it's a much more slow onset and often is asymptomatic until you get later into the disease. So here's a picture again of our stem cell. We looked at something similar to this a few weeks ago. So we have the lymphoid line and the myeloid line, but here we see, so erythroid leukemia, megakaryocytic leukemia, so other types besides just white blood cells. And this is just another more detailed picture with the pluripotential stem cell, that originating stem cell that gets differentiated into these various types of cells where we can see a variety of leukemias interfering there. So one of the things that we look at, we talked about this a little bit last week when we talked about neoplasia in general, but the 5-year survival rate is something that we track pretty closely in cancers. And this is data from 1990 to 1995. I haven't seen more recent data, but it does demonstrate again that disparity in survival rates based on your ethnicity, which doesn't appear to be anything that we can track down except for things like access to care, quality of care that's administered. We know that 2 people who go into the emergency department with different ethnicities get different care. And you'd think in 2010 in the United States that wouldn't happen, but it still does. So acute lymphocytic leukemia primarily is a B cell leukemia where we have those blasts, those immature cells accumulating both in the blood and in the bone marrow. Tends to affect young kids, although there is another peak of incidence in middle age. The survival rate for kids is always better than it is for adults in all the different types of cancer. So if you get these as a child, your survival rate is much higher. So 91% for kids under 5, which is not bad. 61% overall. Acute myelogenous leukemia then is an acute leukemia of the other family of white blood cells. Neutrophils are most commonly affected. This is 80% of all adult leukemias. So if adults get leukemia, it tends to be myelogenous. The median age is 50 years, and again, the survival is much better for kids than it is for adults. Here's a little case study of an adult with acute myelogenous leukemia, previously healthy 55-year-old man who comes in with swollen gums. He's got shoddy generalized lymphadenopathy. So lymphadenopathy, we looked at the picture last week as the swollen lymph nodes, and shoddy means it's like gunshot, like buckshot, you know, what do you call those little pellets? BBs, yeah, that kind of feel to it. palpable spleen and ecchymosis on his bilateral lower extremities. His white blood cell count is 96,000, so normal is 5 to 10,000, so his white blood cell count is 96,000 with 50% blasts, so all of those immature cells. So you can come in with a low white blood cell count, but in many cases people are admitted with a high or diagnosed whenever they come into the healthcare system with a high white blood cell count. The diagnosis, acute myelomonocytic leukemia, and then chemotherapy was administered to this patient who had complete resolution of his signs and symptoms and his disease. Now, what I don't know about this picture was the condition of his teeth before he was admitted, because they look pretty bad. I think that was probably pre-existing. Then chronic lymphocytic leukemia, again, mostly involves B cells. This is often asymptomatic and it affects adults only, and the median survival is 4 to 6 years, but the average age at onset is in the 70s. So you wouldn't expect your life expectancy to be much longer than that at that age anyway. But it does have a pretty good 5-year survival rate. And then chronic myelogenous leukemia, one of the forms of this that we see is that genetic form that's related to what's called the Philadelphia chromosome. And we mentioned this, I think, a little bit last week, where there's a translocation between chromosome 9 and 22. A piece of genetic material gets switched, and it's that ABL piece. And that genetic mutation or alteration is present in 90% of cases of CML. The median age is 40 to 45 years, 5-year survival rate's about 50%. And then we mentioned last week this drug Gleevec is used in GI tumors, also used here in leukemia as well. So we don't really know what causes leukemia. There's a lot of theories about what happens. Clearly with the CML, there's a genetic link there, but there may be other genetic characteristics as well. Viral, we talked last time or a time or two ago about the Epstein-Barr virus and how connected it is with a lot of things. Certainly exposure to carcinogens in the environment, in the workplace, wherever can increase the risk of leukemia. And then this is a wide range, I know, but you see different sources. So somewhere between 1 and 20% it results from patients who got radiation or chemotherapy for some other cancer. So they were treated for cancer, some other kind of cancer, and as a result got leukemia. If the bone marrow is suppressed, we see suppression of the 3 different types of cells, the red blood cells, white blood cells, and platelets, putting people at risk for bleeding, for infection, and for anemia, signs and symptoms of anemia. And then if the tumors infiltrate into solid tissues, we see other kinds of symptoms like spleen or liver enlargement, if it gets into the joints, swelling and pain, and so on. The diagnosis of leukemia is based on the white blood cell count with a differential looking at the various types of white blood cells that are present, and then a bone marrow biopsy to tell us really what's happening in the bone marrow. The goal of treatment is to induce a remission, and then certain kinds are more responsive to chemotherapy, and then some kinds are more likely to be bone marrow or stem cell transplant. And who works in the, is that you, Tara? So is that what you see? So with AML, if the first round of chemotherapy doesn't work, you may continue with chemotherapy and then do a bone marrow transplant. Complications that we're concerned about, nutrition is always an issue. We talked a little bit about that last week, infection. And some places are doing neutropenic precautions and some places are not, depending on what their philosophy is. But often when the neutrophil count gets really low, then we do neutropenic precautions to protect the patient from infection. Things like having no fresh fruit or food, no fresh fruit at all, no flowers in the room. People who are sick can't visit the patient. Having the patient wear masks when they go outside of the room. So those kinds of precautions. And then bleeding and anemia we mentioned, and then pain, the other big complication that we're concerned about. The biggest cause of death in these patients is infection because of their immunosuppression.
Did you say no fresh food or fruit?
I said fruit first, but I should have broadened that to food, any kind of fresh food, anything that's uncooked. So no raw carrots, no raw food at all.
Actually, and if they're peeled.
If it's peeled, yeah.
Because it's the pathogens are on the skin.
On the outside, yeah. So, and different facilities have different policies, so.
Do they give GCSF before they've eliminated the problem, like before they've killed off the cancer cells? It seems kind of counterintuitive to give.
Well, we give GCSF, granulocyte colony stimulating factor, to patients with low white blood cell counts. I'm going to have to rely on our experts. Do they give it before the cancer is? So give the chemotherapy and then a few days later come in and give the GCSF. Because you don't want to stimulate a whole bunch of new white blood cells and then just kill them off with chemotherapy. Yeah. Is that the theory? Yeah.
There's some controversy around that, especially with AML, because that's where the GCSF is stimulated.
Uh-huh.
But the jury's still out whether that will actually stimulate one of these cells. Yeah, usually they'll do the ablative chemotherapy or whatnot, and then they'll do the GCSF anywhere from 7 to 14 months.
So one of the concerns is that by giving GCSF, we would trigger multiplication of leukemic cells, not just forming new cells, new good cells and killing them off, but actually stimulating leukemic cells to form. And so there's some controversy about how to do that.
My sister got the AML in 2007 and died in 2008.
Oh.
But she was cancer-free at the time, but due to neutropenia problems, and she
Uh-huh.
got pneumonia. And, but what really turned her around, because they did a bunch of multiple chemo. At that time, 2005 is when Gleevix was approved.
Mm-hmm.
And Gleevix was the fastest approved cancer drug ever. It was approved within the 2-year time frame. And basically, that drug's been basically turned her things. They basically had used Gleevix in the second study, and basically did it on 58 people. And basically, these are people that failed all forms of chemo. And of those that failed all forms of chemo, 58% were cured just with Gleevix after they failed all chemo. So it gives, what it does is it binds to the protein binding site on the cancer cell itself.
Great, thanks. So explanation of Gleevec and how it was approved, and yeah, thank you. Okay, so we talked about leukemia. So lymphoma is where we see those lymphocytes, mature lymphocytes being multiplied rather than in the stem cells in the bone marrow. So, and it's initially localized in the lymph tissue itself. Hodgkin's lymphoma is about 12% of lymphomas, and then the rest of lymphomas are non-Hodgkin lymphomas, other types. So you can read this as well as I can. The big thing to think about with Hodgkin's lymphoma is those Reed-Sternberg cells. They're the cells that are present in that form of lymphoma that identify it as being Hodgkin's disease. And then Hodgkin's lymphoma tends to have a better prognosis than other types of lymphoma. So those Reed-Sternberg cells, we're still trying to figure out what those are, if they're macrophages or some other kind of lymphoid cell. One thing we see is a lot of them have Epstein-Barr virus in them, which is interesting because here it comes again. The median age is 30 to 50, but you tend to think of this as young adults, although it does happen in older people as well. Yes?
I had an uncle who's, now had Hodgkin's lymphoma diagnosed when he was in high school.
Uh-huh.
And the treatment at the time, when they found this doctor, he was like, well, let's try radiation to cure him. I think it was a year of radiation treatment, and that was in the 50s.
Yeah.
So that was experimental, and he's still alive today.
Wow. So a relative with Hodgkin's disease as a young man treated with radiation who's alive today. Yeah, great. So non-Hodgkin's lymphoma is in lymph nodes and other lymphoid tissue. This tends to be a little bit older population and much more common in a larger number of cases because the Hodgkin's accounts for only 12% of lymphomas. And this comes from a variety of cells, and again, one of them is T cells that are infiltrated with the Epstein-Barr virus. And then there's also a T-cell lymphoma, and that's caused by the HTLV1 virus. Anybody old enough to remember? Does that trigger something for you? What did the HIV used to be called? When it was first identified, it was HTLV3. We renamed it then HIV, but a related kind of virus here. And then multiple myeloma is a malignancy of the plasma cells, those specialized B cells that produce the antibodies. This can be an invasive type to get actually into the tissues, not just circulating in the bloodstream. And this one has an antibody associated with it, which is a protein, and all antibodies are proteins. And so we see this protein in the urine called the Bence-Jones protein. And so that's diagnostic for this type of malignancy. So I think we'll stop and take a break and come back at 6:30.